So now we will move on to our healthcare program, and we have two wonderful ladies who will be joining us today, and I will go ahead with their introductions. Dr. Nicole Ehrhart is the director of Colorado State University's Columbine Health Systems Center for Healthy Aging and a full professor in clinical sciences at the College of Veterinary Medicine and Biomedical Sciences at CSU. She holds the Ross M. Wilkins Limb Preservation Foundation University Endowed Chair in Musculoskeletal Biology and Oncology, a real tongue twister. She, along with her colleague, Dr. Greg Ebel, is leading a statewide weekly COVID-19 testing program to identify people infected with COVID-19 living or working in senior residential care communities in order to serve as an early warning mechanism to prevent or mitigate COVID outbreaks. Our second guest is Dr. Rebecca Jackson. She is the Geriatric Medicine Specialist and Medical Director at Columbine Health Systems. Dr. Jackson completed her undergraduate degree in biology at CSU, her medical degree at Kirksville College of Osteopathic Medicine, a medical residency at the Family Medicine Center in Fort Collins, and a fellowship in geriatrics at Oregon Health Sciences University. The topic of their presentation is COVID-19 testing, Colorado State University and Columbine Health Systems, a research partnership. And if you ladies could keep your presentation to approximately 20 minutes, we would much appreciate it. We are very anxious to hear from you, so please proceed.
Thank you very much, and good morning, everyone. I'm so honored to have a chance to share with you some of our work that's been ongoing at CSU and in partnership with Columbine Health Systems. I am going to go ahead and share my screen. I have a few slides I'd like to share with you about our program. Let's see if I can just get, oops. Let's see, slideshow. Okay, so one might ask the question, why a aging research center at CSU? And the reason for this is number one, we've been for many years very active in aging research, both from the basic biology aspects to the social sciences aspects, but really had no central place to kind of coordinate those research efforts that traditionally have been siloed across campus until Columbine Health Systems was gracious enough to provide a large multi-million-dollar gift to create the Center for Healthy Aging at CSU, which exists at the health center there on College and Prospect. So why dedicate a research center for aging at all? Well, as you probably are aware, the number of people that are aging in the world is growing. In fact, in 2019, the number of new births declined below the people that were over the age of 65. And by the year 2050, the number of Americans 85 years and older is going to triple. And that means that globally, 65 years and older people will rise to nearly 24% of the entire global population. So clearly we have an aging world, but not only that, we have a high burden of age-related diseases. And as you probably are aware, the average 65 to 69-year-old person takes 14 different prescriptions. We spend $30 trillion in Medicare over the next 20 years, estimated. Alzheimer's disease, diabetes, heart disease, et cetera, and cancer, which are age-related diseases, may represent about 80% of the US Medicare budget. And it's been estimated that if we could slow aging even by 20%, we could save the United States $17 billion over the next 10 years in healthcare costs. So this is a huge area, 17 trillion, I misquoted that. I mean, a huge potential benefit to see what we can do to slow aging. So the Center for Healthy Aging, again, made possible by Columbine Health Systems, is a catalyst to unite interdisciplinary research and evidence-based outreach to improve lifespan and health span. And there are various core activities, but essentially what we exist to do is to create interdisciplinary team science that bridges us to rapid translation to novel treatments or interventions, and then bring that to the community and have the community engaged in our activities on campus. So this talk is about our COVID-19 activities. And as of course you know, the pandemic has highlighted the vulnerability of people that are living in residential care communities. This includes group homes, correction facilities, communal living situations. And certainly residents that live in skilled nursing and assisted living facilities are particularly vulnerable to infectious diseases. And this is because they require day-to-day care. They often have multiple health conditions and are typically of an advanced age. And as this has unfolded, what we've discovered is about 40% of the deaths from COVID-19 nationwide are actually in long-term care facilities. These are some data from the state of Colorado showing the number of deaths related to COVID. And in Colorado, the percentage of deaths related to COVID, 53% of them have been in skilled nursing facilities or assisted living care facilities. So you can see that we're facing a very significant issue. So what I want to do is walk you backwards a little bit to the beginning of the pandemic and what started happening on campus in terms of our thinking and response to this. And of course, the first COVID case was reported in Colorado in March. And at that time, due to public health mandates, senior living communities discontinued visitors. And the guidance at the time was to screen all staff daily for COVID-19 symptoms, things like fever, cough, known travel, known exposure. And the idea there was we would hopefully prevent people that had symptoms and therefore were infectious from coming to work and spreading the disease among workers or the people that they were caring for. And also, I'm sure you remember the extreme difficulty in testing availability at the time. That at the time, the CDC test that was available was only available for hospitalized patients and people that had severe symptoms, and there really was no testing available elsewhere. So at CSU, we had several concerning issues because we understood there was a potential emerging threat to older adults. We knew that the CDC test that had been initially rolled out had contamination issues, and that had resulted in a bunch of delays in our ability to test. The diagnostic testing at the time was limited only to state labs, and all testing at that time was directed to the sick, but nobody was really talking about silent carriers. It really wasn't even known whether people could be asymptomatic and actually be infectious. And at CSU, we have a very good infectious disease program with a lot of biosafety level 3 space that's unique to our campus. And the research labs at CSU represented an untapped resource for special population testing in Colorado. This is a PCR test that we could perform in our research labs. And so we actually knew that we could scale up and operationalize surveillance efforts through CSU if we could deploy them quickly. And we knew that we could do it inexpensively. We also knew that the Center for Healthy Aging had already been establishing relationships in skilled nursing facilities for aging research, i.e. Columbine Health Systems and others. And then my colleague has been doing surveillance for virus such as West Nile for many, many years. And so the two of us put our heads together and said, how can we help? This is obviously a crisis, and time lost is lives lost. So we really wanted to deploy this quickly. But of course, we had a bunch of challenges. We had supply chain issues. We didn't have swabs. And we were not, as we were doing this in a research lab, even compliant with regulatory guidance or policy. So we went to the governor, Governor Paulus, and asked him to provide a special letter of assurance to allow us to perform this in a time of public crisis. And we received that letter. Then the other problem was we had absolutely no funding to do this. We just basically bootstrapped together money that I had received from my startup funding from becoming the director, and people volunteered, grad students, postdocs, funds, supplies. CSU grad students served as couriers, and we just got the program started on a wing and a prayer. So the program that we did was we recruited healthy people working in skilled nursing facilities from 6 different facilities in Colorado, and they consented to be part of our project. They had to have no COVID-19 symptoms and no known exposure, and they had to consent to let us swab them weekly over 8 weeks. And if they were positive, then they agreed to self-isolate and continue to be tested in the program. And then if we found a positive, we would then confirm that by CLIA laboratories at CSU and another independent laboratory, just to be sure that our results were aligned with a CLIA lab. And what we learned was really alarming. And again, this is quite early on, that 15% of these enrolled workers were positive for the virus, and yet they had 0 symptoms. They were coming to work, they were doing the best they could to protect the people that they were serving and caring for, and yet they were actually positive for the virus. And we found that not only were they positive, but not only direct care staff that were positive, but people in administration and maintenance and other areas were positive too. So this was probably the first real recognition back in March, April, May that there were a number of different asymptomatic positive people, and this was potentially kind of a Trojan horse that could be a threat to older adults. The other big question among the scientific community was, well, if you're not symptomatic, and even though you may be positive for the virus, can you actually infect others? And the way we tested this was a test called a plaque assay that essentially tells us whether or not the virus that we are getting from a swab on a positive person can actually infect cells. And indeed, these people were infectious. Not only that, but we were able to do deep sequencing of the genome of the virus, and we could show that these viruses were very related to each other, that instead of being imported from the community multiple times over and over into a facility, what was happening is that the facilities, within facilities, it would spread among workers in those facilities. So we were able to conclude that the screening for these COVID-19 symptoms, as was recommended at the time, was not sufficient to identify people that could be infectious to others, and that people that didn't have symptoms still had high virus loads and they were infectious, that identifying positive workers over time and having them self-isolate actually diminish new outbreaks. And we showed this definitively in our data. And that if we could do weekly testing, we could potentially set up an early warning system as well as a mitigation strategy to combat outbreaks in nursing home facilities. So we presented our data in May to Governor Polis. This model of weekly testing then became the Colorado standard from that time forward. The state funding is now completely funding weekly testing programs for staff in all skilled nursing facilities and assisted living facilities in Colorado using our platform and our program. The CDC then requested our results and our samples, and that weekly testing model has now become the national model for healthcare workers around the nation. And of course, CSU's Columbine Health Systems Center for Healthy Aging has now become a national leader for response during the pandemic in protecting the lives of older adults and residential care populations. And these are the lead investigators, myself and my colleague, Greg Ebel and Christy Pavalonia, who have been absolutely instrumental in allowing us to perform this very important research, and many, many others, including our state government, our campus partners, and of course, Columbine Health Systems. And from here, I'm going to turn it over to Dr. Jackson, who is going to share sort of how this all played out in real life in their programs.
All right, I'm going to try to hustle through things since we do have the governor coming on soon. So, but we've been traveling through this COVID journey at Columbine.
Rebecca, this is Steve. I'm going to interrupt you for a second. I think at some point I said that the governor was coming on at 12, and he's actually scheduled for 11 o'clock. So I just wanted to make that clear to everybody. Sorry.
No, it's all good. And if someone can just let me know when he arrives, we'll wrap up so that he can, take priority. So, but yes, we actually had the index case in Northern Colorado return from traveling abroad and work at our nursing home in Loveland. So we experienced the first outbreak of COVID-19 in Northern Colorado. To say that we were not well equipped as a country to cope with what we were dealing with at that time was really an understatement. And I will admit we had the best support possible. We had CDPHE, we had Larimer County, we were in daily communication with them. We even had someone visit us from the CDC. So we really did have some great guidance, but despite all of that, there were some barriers that Nicole did a really great job of touching on. PPE masking was a huge issue for us initially. We had to do some navigating and some crisis standards to make sure that our staff have adequate PPE that they need. The symptoms were broader than initially told. The respiratory symptoms were primary, but obviously there was a lot of asymptomatic spread that we weren't even aware of in addition to other symptoms. So really it was hard. What's hard about COVID is you can't really trust your clinical judgment, right? So it's once you think it always teaches you something else. And so really you do need these clear, reliable data points in order to make decisions for your residents and your staff. And testing, like Dr. Ehrhart said, was just so limited, and the turnaround was really rough at that point in time. We were waiting 1 to 2 weeks to get tests back, and we really struggled to make good decisions based on late information. So that was also something that helped us cohort residents too. And you probably have heard about COVID units within these facilities, and you really can't develop a COVID unit without knowing where it's at. So testing was a huge hurdle for us, and North Shore was a struggle. We lasted for just 1 second. Sorry. Talk about daycare struggles. I am navigating children at home today, so I apologize. But we lasted 72 days in Loveland with that outbreak. It was actually quite, it was a very long journey. And later on during the summer, we joined up with CSU, and we were so grateful for the consistent testing and rapid results that they provided, which typically came in under 48 hours. We continued the surveillance testing. We thought we kind of knew what we were doing this summer. And then in August, we realized that we were on the verge of a very large outbreak at our sister facility up here in Fort Collins, Columbine West. At this point, our testing with CSU was really well established, and they were so reliable, getting us those results back promptly. And because of that, it felt so different than any of the other outbreaks that we had been through, because we were able to clearly see where it was, identify it, isolate our residents, and take prompt action. And then this also happened to be the time period where we received our point of care testing from CMS. And while those tests have been somewhat controversial, it did serve a role during this outbreak. We used it along with the PCR, which is the gold standard, to screen all staff before coming into the facility. We were able to turn away asymptomatic staff and not have them come to work and prevent further spread that way. And it really was a game changer for us to have, access to those two tests. So I will say CSU stepped up for us in a big way during this outbreak. They allowed us to test every 3 to 4 days, which really allows you to isolate where you're looking for the disease. And 1,200 tests later, we were able to contain the spread, and we were able to close our facility. So close our outbreak in 33 days, which was just tremendous. And I can't even tell you the financial benefits of being able to do that. I think it was huge to be able to close that size of an outbreak that quickly. So kind of in summary, like, COVID knows no bounds, nor does it care about what your 5-star rating is. And I think one of the things that can make us really vulnerable is our physical layout as a facility. Also, we have shared rooms, and certainly our facility at West had this. And I'm sure you guys have heard about Kirkland, the facility out in Washington that suffered such a severe outbreak. And I really think had we not had access to testing, that it could have had that potential to spread so broadly. So I will just say that, after reflecting on 2020, it's really, COVID's exposed a lot of the cracks in our society, resulting in a lot of unrest. And I hope that someday that COVID will show us just how much we have in common and what's not different about us. And I just want to say that, my patients teach me profound things every day, which is why I love geriatrics. And I think through this outbreaks, I have seen that we really need each other. Connection to one another is as important as the air we breathe. So I cannot send enough gratitude to the connections that we have through the state, through CDPHE. They've been tremendous for us. Our community here in Northern Colorado, including our partners at the local hospitals, as well as our Larimer County Health Department, who was just a rock for us during this time period. And I can't even begin to express my gratitude for CSU. They have made something that seemed so impossible back in March manageable. And as a result, we've saved lives and really provided a wonderful service for this underserved population. So, and as I've told Dr. Ehrhart, I've never been so proud to be a CSU Ram. So I just really appreciate you inviting us and allowing us to be part of the conversation. And it looks like Governor Polis is here, so I'm going to wrap up. Thank you so much.